I'm Dr. Randall Thomas from Orthopedic Foot and Ankle Center. Today we're going to talk about hallux rigidus, more commonly big toe joint arthritis. So hallux rigidus is an end-stage progression of arthritis at the big toe joint. The big toe joint ends up either from a malalignment, such as a bunion, or wear and tear, breaking down over time, becoming inflamed, losing cartilage, having defects in the cartilage, and becoming arthritic, having spurs and limited motion. We see this where the joint narrows. Hallux limitus and rigidus are a term that's kind of synonymously used, but hallux limitus means that we're starting to see limitation in motion. It's the early stages of this arthritis process. Hallux rigidus is the more advanced stages of the arthritis process in the big toe joint, meaning we really have no motion in the big toe joint. It's a severe bone-on-bone, patients commonly say, arthritis. The symptoms are a lot of pain at the big toe joint and can also include inflammation such as redness and swelling. It's interesting that this is a condition that's commonly mistaken for gout. Patients will say, I've had gout for several years, I take steroids, it may get better, however it lingers for weeks. If I overdo it or have high impact activity, it'll have pain at the big toe joint. In gout, the symptoms resolve much quicker. And that fact, it gets red, hot, and swollen. Within a few days, it gets better. Can respond to the medications that arthritis would respond to. Usually has to do with diet changes, not necessarily activity. So hallux limitus and rigidus is very painful for patients that have difficulty walking upstairs, difficulty walking downhill. Any motion at the joint can give a sharp pain. A lot of times patients start to walk more on the outside of the foot by the baby toe and guard and not put weight by the big toe joint. The causes are typically the structure of the foot and degeneration over time. The structure of the foot can lend to more pressure at this. We know in higher arch foot types there's more pressure at the big toe joint. Certain athletes and sports from the past can lead to wear and tear of that joint. This is our primary weight-bearing joint for the foot. The majority of our body weight goes through the big toe joint. So as we have more birthdays, we get more degeneration of the joint. Sometimes we can have an injury and post-traumatic arthritis. You stubbed the toe years back, you dropped something on it, walked it off, didn't think it was a big deal, and this process started. Over time, you develop more spurring and limitations in motion. So some folks can also get it if they have more autoimmune conditions or global arthritis conditions, such as a gout arthropathy, psoriatic arthropathy, rheumatoid arthritis, those types of conditions. Typically diagnosed by physical exam and x-rays. In the setting of concern of gout, where it can be misdiagnosed, sometimes primary care providers get blood draws to look at that, to look at a uric acid level. We diagnose it typically by physical exam and x-ray. There's different classification systems for how much of the joint is broken down, how much spurring, how much lack of motion. Fairly common, a lot of times can have a concomitant bunion deformity that leads to this. If the bunion has a misalignment of the joint, then the joint starts to wear down and get more arthritis over time. With x-rays we can see this, but also we get MRIs at times. Less commonly CTs and ultrasounds, particularly for looking at the mechanics or other aspects of the foot from a joint and mobility standpoint. The MRI will tell us how much cartilage is lost or their cartilage defects and give us a kind of a grading system. This grading system helps us plan for what procedures or conservative treatments we're going to do for patients. Treatments can be non-operative or conservative a lot of times. We're trying to hold off the symptoms, although it may be a progressive condition and worsen. We're a lot of times not having to employ surgery on these. Typically it starts with inserts, custom inserts that we make molded to the foot that have an elevated piece or what's called a Morton's extension to hold the joint and protect it. Sometimes we do, like you would treat any other arthritic joint throughout your body, steroid injections, bracing, splinting, physical therapy modalities. There's ways to do carbon fiber inlays to decrease shock absorption on the joint itself. Some mobility work to try to maintain what motion we have, although this can sometimes lead to more pain with more mobility. Offloading and rest, if these were going to go into surgical care, if the patient didn't respond to conservative treatment. And this could include kind of three classifications. One with hallux limitus is what we would call a chylectomy of the big toe joint. And that's where we clean out the bone spurs, try to clean out as much arthritis as we can, create more mobility at the joint, and try to help with realignment or soft tissue balancing. That's if we think we can spare the joint. As you get into hallux rigidus, where the joint can't be spared, and it's end-stage bone-on-bone arthritis, then we have essentially two options. One is a joint replacement or a joint fusion. I will tell you that patients do very well with fusions. The patient satisfaction scores are high. The activity level is higher than you would think. We usually tell patients that want to wear fashion shoes or high heels to limit it to about 2 inches on a wedge or a high heel after a fusion. In a replacement, you may be able to wear a more variety of shoes with an artificial joint. However, the artificial joints don't work as well based on the way they weight bear compared to joints, say, in a hip or a knee or a total ankle. And that has to do with the mechanics of it, and you can't be as active. With fusions, you can be very active. There are professional athletes that have had fusions in their careers and played at high levels. We have patients doing high impact activity, marathons, HIIT training, other exercises. The fusion may sound scary, but it eliminates the pain because it makes it one block of bone, and it also doesn't allow for recurrence. One of the concerns about replacement or cleanouts of the joint is you may have to go into another surgery in your lifetime for a fusion. The fusions involve plate and screw constructs holding this in position. These are made for this joint, so they're not prominent. Patients don't feel them. They're underneath the soft tissue, usually don't have to be removed. The joint replacements are titanium type of replacements. Each has its own risk and benefit, and that could be discussed by your foot and ankle surgeon. The recovery varies based on the procedure. If we're doing a chylectomy for hallux limitus, we're trying to get mobility and keep that to the joint. So we actually want the patient walking early on in the recovery process. Goal being by week 4 to 6 being back in regular shoes, and then after that advancing by week 10 to 12, no restriction in activity. For the fusion, it's about 1 week at minimum off the foot, sometimes up to about a month off the foot, and then transitioning to a boot and walking in a boot. Goal being by week 6 that we're in a surgical shoe going to physical therapy or doing rehab on your own. As we get to week 8 to 10, getting back into regular shoes, and hopefully by week 12, back to regular shoes and starting high impact activity. For the joint replacement, we want to maintain mobility early on. Typically we're off the foot for about a week to 2 weeks, and then we start doing some range of motion work, increasing our activity level, going from a boot to a surgical shoe, and then eventually to a regular shoe. Of course, we'll have some restrictions long term with the replacement, whereas a fusion, once you get past the first few months, there would be no restrictions. These swelling can be an issue with this and can take up to 6 to 9 months to go away entirely. But the recovery is pretty quick for back to activity, and even for folks that are doing their right driving foot, the hope is within a month or so being able to drive and get back to regular activity and having about a week off where you're completely non-weight bearing than doing partial weight bearing. And that would vary based on the individual patient and condition, and that could be discussed with one of our providers. The risk is low. Complication is inherent to any surgery potentially. Risks such as infection below 1%, blood clots below 1%, hardware is being implanted, and depending on what you read, there can be up to 3% or so risk of needing to take out hardware in the future. One of the other risks we see is non-unions and fusions, where the bone doesn't grow together. Patients that have comorbidities such as diabetics or other immune problems, patients that are smokers can lead to problems with healing the bone and losing blood flow to the bone. So we want to screen for that early on and make the right procedure for the right patient and individualize our care to the patient. So the concern of the non-union is there with fusions. That doesn't occur with joint replacements. One of the issues there would be joint stiffness or displacing of any of the components of this, which could occur depending on patient compliance and activity level. With the joint cleanout, we could see more pain, and that's one of the reasons we get more advanced imaging such as MRIs. If we go in and do a joint cleanout of an arthritic joint and we create a bunch of motion and we're grinding without cartilage bone on bone, that could lead to more pain. So you want to make sure that you've done all the appropriate imaging and workup for this. You essentially could make a patient worse if you go in and clean out an arthritic joint at the big toe joint and you don't do anything else. If it's too far gone with arthritis, it will hurt more and very quickly they'll have to go in for another surgery such as a fusion or replacement. Patients will oftentimes, they'll see a big spur on the x-ray, they'll see that the joint's narrowing, they'll feel popping and clicking in the joint, they'll have pain and inflammation, and they say, okay, can I wait on this surgery or do I need to do it right away? I think there's a good point where if it goes beyond a certain amount of arthritis, maybe you do wait. If it's looking at, can I clean out the joint now, but I guarantee I'm gonna have to do another surgery within a decade, you go ahead and wait, right? Wait for the arthritis to get worse and then fix it. A lot of times we tell patients, much like the total joint patients, let's live with this as long as we can, and when you can't stand it anymore, let's fix it. And I tell patients, you'll know when that is, because you'll decide that you're not doing activities based on the arthritis and the pain in the toe. You're saying, I'm not getting out of the house or not getting out of the chair today because it hurts. And so sometimes we wait for that and we try to do the conservative measures like steroid injections, inserts, shoe modifications, topicals, until they get to that point, then we just go with the fusion. Again, with the risk of having to have another surgery with a joint replacement or a joint clean out or cheilectomy, a lot of times we try to do symptom control until we can get the patient onto a fusion. We want to do appropriate imaging, such as an MRI, to be able to grade the amount of arthritis accurately and prove that the pain is from this and not from some other condition around the big toe joint. And then once we know that, we can make a decision, do you wait or not? And that's individual to each patient's tolerance and what their goals are.